Okay, just in case people didn't hear whenever Anna was announcing it, the Zoom meeting's being recorded, and it's going to be, the first half of it I think is going to be posted online. So if you don't want to be in the recording, make sure that your camera's off, and that should hopefully be okay. I don't think the breakout rooms or anything like that are going to be online. So I just want to welcome everyone today and say thank you very, very, very much for taking some time out of your day to attend this workshop, because I'm aware that obviously it's a very intense time in general, and especially in the healthcare sector, so it means a lot for people attending. And the workshop today is going to focus on refining the guidance for implementing a volunteer-led arts programme within regional haemodialysis units. So this is an ESRC funded project that's going to look at essentially developing guidelines to get volunteers into units doing art with haemodialysis patients. Now, just a little bit of an overview about what we're going to do today. The first thing is just the welcome and the introductions, and then we're going to give you a bit of an overview of the background of this project, so why we're doing it, why art, why haemodialysis, and the issues that we're trying to address specifically. We're also going to give you a bit of an idea about what a dialysis unit is like. I'm not sure how many people here haven't been in a haemodialysis unit, but there might be a few. I know that a lot of you obviously work in that area, but for those who haven't, I think it's important to get an idea of the context. Then we're going to give you an overview of like the background, the research background of this project, because this project has built on research done at the School of Nursing and Midwifery at Queen's University Belfast and in the Northern Health and Social Care Trust. So I'll give you a bit of a background about the science behind it, and then we're going to give you an overview of the guidelines that were sent around, I think, by email with the Zoom invite, but I'm not expecting people to have read that in any depth. If you have had a chance to look at it, that's great, but we'll give you sort of like the key points just in case, because obviously everyone's very busy. Then we'll have a comfort break, and then whenever we come back, we will be doing an arts activity. It's just for fun. Don't worry too much about it, because I do know that art can make people a bit anxious. It's just to sort of wake you up a little bit after the comfort break and give you an idea about how to do art remotely. And then we're going to have a discussion of the key questions that we have about the guidance. We're going to go into breakout rooms to discuss that. Then we'll all come back and feedback on those, and then we'll finish up. So that's the general overview of the 2 hours, where hopefully we'll get through it with no issues, depending on how time goes. But the first thing I want to do is have people introduce themselves. The issue today is that we have quite a few attendees, so it would take quite a while to go around and have everyone introduce themselves individually. So what I'm going to ask is for people to, if you can see the chat box, if people could put in their name, where they're from, and why they're here, in terms of like, are you a renal patient? Do you work in renal? Are you an artist? Do you work in the voluntary sector? To give people an idea of who's attending. So if we can pop that in the chat box instead of going through, I'll pop myself in as well.
We need some background music, Claire.
I know, it's just silent. I'm not sure if everyone's had a chance to put in yet, but got quite a a good few people attending, mostly from kidney background and the healthcare trust, but yeah, I've got quite a wide variety of experience here. Very good. So yes, everyone's very, very welcome. Thank you so much for coming. Yep, and it's lovely to have you all here, and I think that's quite a good mix, and we should hopefully get some good discussions out of everyone. So as I mentioned, we're going to give you now just a quick overview about why we're doing this in the first place. So why art and why hemodialysis. For those of you, I don't think there'll be very many people, for those of you who don't know, hemodialysis is a treatment that people receive whenever their kidneys fail. So people with end-stage kidney disease receive hemodialysis. And it's a very difficult and time-consuming treatment. So patients have to attend hospital 3 times a week, every week, for 4 hours each time. During that time, they're connected up to a dialysis machine. The dialysis machine drains and filters their blood and sort of replaces the role of the damaged kidney. Now, while they're on hemodialysis, they are restricted to a chair or a bed, and they have very limited opportunity to engage in meaningful activity. Most people just try to sleep or watch TV. And because of that, the time on dialysis can absolutely drag in. And in the literature, the experience of hemodialysis has been described as one of existential boredom, because a lot of patients are left with nothing to do except lie there and think about illness and death. And understandably, this has quite a profound impact on patients' mental health and well-being, and patients receiving hemodialysis are at a significantly increased risk of developing mental health issues such as anxiety and depression. Now, art might be ideally placed to address this issue on hemodialysis, because whenever people engage in art, they can enter into something called a flow state. And a flow state is essentially a state of mind that people get into whenever they're completely absorbed and engaged in an activity. And because you're completely absorbed and engaged in activity, you don't pay attention to what's going on around you. You don't pay attention to thoughts in your head, so you're not worrying, you're not ruminating, and you're not really paying attention or thinking about anything else except for what's going on in front of you, the actual activity that you're engaging in. And one of the hallmark experiences of a flow state is that it alters your perception of time. So most typically people experience time passing a lot quicker than it actually is. And for patients receiving hemodialysis, when the time seems to drag in and people are just watching the clock, this could be tremendously beneficial if we're able to induce a flow state. Now, I think that most people here are very familiar with hemodialysis units, but there are probably a few people here who maybe haven't been on a unit or aren't too familiar with the hemodialysis process. So I'm going to hand over to, first of all, Ellen Walsh, who is a home dialysis nurse from Belfast, who's going to give you a bit of an overview about what sort of clinically a hemodialysis unit is like. And then we'll pass over to William Johnston, who is a renal patient who'll be able to describe his own experience of hemodialysis. So Ellen, if you'd like to say a few words.
Ellen has said she's lost her connection. Oh, you're back on, Ellen.
I'm on in both my laptop and my phone, so I don't know if you can see me or not.
I think there's a bit of an echo.
Why don't you start with William?
Okay, William, would you like to go first?
While Ellen sorts things out, yeah. Is that all right, Ellen?
Yep, yeah, I think I'm okay now. I've got my laptop.
Oh, that's all right.
Yeah, that's
better.
But I think the camera's working on my laptop, so you're going to see some funny facial reactions from me in the when it went wrong. But anyway, we'll go ahead. Yeah, so I'm just going to speak a wee bit about what it's like to work in a hemodialysis unit. I am a home dialysis nurse, but I've had experience in a hemodialysis unit before this. It's busy. There's long shifts. Some hemodialysis units have 2 slots running from 7 a.m. in the morning to about 11, and then a second slot then in the afternoon. And other units have 3 slots, which the third one then going in to running into midnight. It's very much routine, although persons entered at the same time. Lots of lining, priming machines, safety checks, admitting the patients in for their treatment. which has made so much more difficult by COVID. Now the patients come in, they have to have temperature checks, they're trying to keep their social distancing, and if anyone does have any symptoms or anything, then they have to go into isolation, which is very difficult when you've only got a couple of side rooms. Patient assessment's very important, and it's quite time consuming as well. And we have a Share HD programme as well in most of the units in Northern Ireland. And it involves teaching the patients how to become more involved with their own treatment, which could run very well with an arts programme, because if they're in a culture of learning and, you know, being involved, then that could run very well into the arts. Yeah, there's lots of the nurses are involved in lots of different routine things, giving drugs, and then of course, you know, EPOs and different drugs that patients require on dialysis. And of course then there's time consuming if patients are unwell or if there's any access issues. But in saying all that there, it's busy, but we like to do our best to keep our patients happy, and you know, things like the Share HD and any sort of arts programme are very good psychologically for the patients. From COVID now, we've got sort of a new patient profile. We've got younger patients that previously, if it hadn't been for COVID, they most likely would be transplanted or they would be on PD, but because of the transplant list be installed and living donations now, that's changed. So anything that could pick up their spirits and get them involved would be a positive. Is anyone any questions or anything that I haven't covered?
No. William, would you like to say a little bit about what it's like to be a hemodialysis patient?
Yes. Unfortunately, I was on dialysis for 17 years, and there was a year on CAPD, 2 years in APD, and then I spent 6 years on hospital hemodialysis, and then I spent 8 years on home hemodialysis. And it was the 6 years of hospital hemodialysis that I found very, very challenging, psychologically challenging, because at that stage when I did the hospital hemodialysis, there was no opportunity to do anything during your dialysis session. You used to just have to come in 3 times a week, lie in the bed and watch daytime television, which was so destroying. So after 6 years of doing that, I was desperate to kind of get to home hemodialysis, where I took control of my own treatment. And it was while I was doing home hemodialysis that I discovered the arts, and I started writing poetry to express my emotions. And it really helped me psychologically to express my feelings and emotions. And that led me on to writing plays. And I actually started to look forward to my dialysis sessions when I was doing home hemodialysis, because I was doing something worthwhile. I was getting something tangible out of my time being spent on dialysis. Well, doing hospital hemodialysis, well, there was no opportunity to do anything tangible. I felt my time was being wasted. So I feel if the arts had been available while I was doing hospital hemodialysis, I would have really enjoyed the experience of hemodialysis so much more. I wouldn't have felt that my time was being wasted. And as Claire says, once you get into a creative activity, the time just flies through, and before you know it, your 4.5 hours of dialysis is up, and you're actually looking forward to your next dialysis session because you're so excited about getting back to whether it's painting or writing poetry or writing a play. So when I did it, when I was doing hospital hemodialysis, there was no arts opportunity, there was no shared care. You weren't kind of given any opportunity to be creative at all. So to me, the introduction of an arts program for hemodialysis would really improve the quality of experience for all dialysis patients. And I would certainly be a great advocate for it.
Thank you, William. Thank you. And thank you, Ellen, very much for giving a bit of an overview. Oh, let me just go back for 1 second. In relation to doing ARTS in a dialysis unit as well, sort of referring back to what Ellen was saying about how busy the unit is and about how there's so many like clinical interventions going on, there are a few things unique to a dialysis unit that have to be taken into consideration whenever you're delivering ARTS in that sort of clinical setting. Most specifically, things like infection control and maintaining vascular access. So again, a lot of you will be familiar with this, but it's very important, obviously, if there's a lot of sort of vascular access going on, that you maintain infection control protocol, because there's obviously a risk of sepsis there. So for example, one way that we got around it was by providing patients with their own individual ARTS packs so that no one was sharing ARTS materials and there wasn't any risk of cross-contamination. The other issue whenever maintaining vascular access is the fact that most people receive hemodialysis through something called an arteriovenous fistula, which is sort of a surgical connection between an artery and a vein that causes sort of the blood vessel to balloon up and strengthen, and it allows for repeated needling. And during hemodialysis, 2 needles this is the most common way that hemodialysis is done, but 2 needles are inserted into the fistula, and those have to be kept in place throughout the 4 hours. Now, dislodgement of one of those needles can be life-threatening because of the amount of blood flowing through there. So whenever you're doing ARTS activities, it's also important to keep in mind that most people, if they have an AVF, are going to be reluctant to move that arm or are not going to move that arm at all. And sometimes that arm isn't their non-dominant hand. So there's a lot of need for practical support whenever you're doing sort of some of the more hands-on ARTS activities. And it's something to sort of keep in mind in this setting. So now just to talk a little bit about the background of this project, because there is quite an extensive background to it and hopefully quite an extensive future to it. So this feasibility study and this project itself came about through the Renal Arts Group at Queen's University Belfast, most specifically William Johnston, who just spoke, and Dr Helen Noble came up with this idea of using ART on hemodialysis to sort of improve the quality of life of hemodialysis patients. They were able to get funding for a PhD studentship to look at the feasibility of bringing ART into a hemodialysis unit, and also to look at the feasibility of evaluating that in a rigorous and scientific way. And I was lucky enough to get that studentship, which was a fantastic experience. Now, because this was sort of a scientific study, because there's not a lot of sort of academic research going on with ARTS, and the academic research that is being done isn't done in sort of the way that would ideally be done in like the health sciences, we needed to develop an intervention that could work within both the confines of a hemodialysis unit, but also the confines of a research program. So we had to develop this as if it were a complex healthcare intervention. So even though it was only technically just ARTS activities that we were doing, we had to take into consideration sort of specifically what everyone was going to do, what choices they would have, the time it would take, what materials they would be provided, and like the theory that underpinned how the intervention was going to have an effect. The intervention that we then developed as a result of that involved 6 1-hour-long one-to-one facilitated ART sessions at the patient's bedside during hemodialysis. These happened twice a week over a period of 3 weeks. Each participant got their own ARTS pack that contained all of their materials, like I mentioned, to maintain infection control issues. And patients could choose between either creative writing or visual arts, and then they could choose different types of creative writing and different types of creative visual art. And every session had a focus on skill development, because that linked into the theory that we were using, which was the theory of flow. Now, the feasibility study involved recruiting patients from Antrim Area Hospital's hemodialysis unit and then randomizing them to either receive the intervention or as into a waiting list control group who would receive the intervention once the study was finished. We did collect outcome measures, and then we also conducted interviews with patients and with healthcare professionals to get an overview of their experience of the intervention, and also the research procedures as well, because we wanted to look at the methodology going forward. Now, we found out a few findings. Most specifically, a lot of the findings related to methodological issues for a larger trial that we want to run, and we're working on that at the same time as this project. But through the interventions and through the interviews and stuff, we were able to find out some sort of thoughts, opinions, and experiences related to the intervention. We found that overwhelmingly patients really enjoyed the intervention, and they reported that it helped improve their mood, it helped improve their self-esteem, it helped pass the time, and it also helped them become more sociable, both with each other but also with the healthcare professionals who were working on the unit. And there are two specific findings from the interviews that I think are important to mention in terms of this project specifically, and that related to the length of the sessions and the importance of the facilitator. So in relation to the length of the intervention and the length of the sessions, patients reported that they wanted a lot more. They wanted longer sessions, they wanted a lot more sessions, and essentially they wanted this sort of arts-based facilitation to continue indefinitely. They wanted this as part of practice. And healthcare professionals also reported the same sort of opinion, that they wanted this to sort of like be instilled and available to patients most of the time. Now that obviously has implications outside of research, because in research you do need an intervention to be time limited to assess things like dose and fidelity. But in terms of long-term implementation, there's obviously cost implications if you want to just have this available at all times to all patients. The other finding was that the facilitator, so the person providing the arts activities and promoting skill development in patients, was essential, both in order to get the benefits for patients, but also to make it practically feasible. Now, this also has implications going forward in terms of how to deliver this in the long term in practice, because I was the one who delivered the intervention. I was the facilitator in this situation. And traditionally in arts and medicine programs where you have an artist come in to provide art in healthcare settings, the person facilitating that would be a professional artist. They would be trained, they would be working as an artist, and that would be their role. But I'm not an artist. I did art to A-level, and then I essentially stopped until I picked up this PhD. So I have no formal training in arts, but we were still able to get this great engagement from patients, and they were still able to find all these benefits, even though I'm an amateur at best. So that again has implications going forward. And this is really how we decided that volunteering was probably the best way to deliver this on a longer term basis, both in terms of making it more sustainable to provide this long term for patients, but also because we find that we don't need to necessarily have professional artists providing this type of arts activities at the bedside. Now the guidance that we sent around, I'm aware that most people probably haven't had the chance to read it because of how busy everyone is, but I'm just going to go through some of the key points ahead of the breakout rooms that we'll be having. So the first thing I think I need to mention, that everyone's probably very aware of, is the fact that the pandemic has impacted this project. It has completely sort of changed how we've had to work around it, because this project actually, got the funding and we started before the pandemic hit. So we'd actually started developing the guidance before everything locked down. And whenever this happened, we had two choices really going forward. One was to assume that the pandemic will pass, and it should pass. All pandemics tend to end, but just to write the guidance as if there was no pandemic, and going forward in the future, whenever the pandemic ends, we would be able to implement this in the way it was originally intended. Or the other option was to sort of recognize the fact that SARS-CoV-2 is going to be with us for quite a while, and develop guidance that could fit within that, as well as in the longer term. And we took option 2. So we've drafted this guidance according to a blended approach where we have both remote provision and direct provision. So remote provision would essentially involve delivering the arts remotely. That would mean that there would be no facilitator present at the bedside to support patients. The participants would still receive their own individual arts pack, but that would be particularly necessary during this pandemic because of infection control issues. Patients would have to be invited to participate in the arts program by staff, because staff would be the people who would have the most face-to-face contact with patients. The arts activities would still be facilitated by volunteers, but it would be facilitated in a different way. So for example, over video calls, so in a virtual way instead of face-to-face. And then those facilitated video calls would be supplemented by pre-recorded online tutorials, which there are a number that the Renal Arts Group has produced already that could possibly supplement some of the arts activities. Then we've also written a little bit about direct provision, which is sort of ideally how this would be provided, which would involve direct bedside facilitation. So there would be one-to-one facilitation during hemodialysis. Again, the participant will receive their own ARTS pack, because in general, I think we need to be aware of infection control issues regardless of the pandemic. Patients would be invited to participate through the volunteer, and that was something that we took away from the feasibility study, was the benefit of having the facilitator recruit the patients, because you're able to answer any worries that patients have, and the worries that patients have tend to be about the ART itself, as opposed to anything else. And then direct provision is probably going to be a lot more accessible for patients, because you can provide that practical support for patients who maybe have either limited dexterity, or they have an AVF, or they have an AVF in their dominant arm, and they just need hands-on help with actually just managing the ARTS materials. So the guidance is written in those two ways, just to help with the blended approach, so that we can do something in the meantime before the pandemic ends. The next part of the guidance that was sort of important to consider is the fact that whenever you're setting up a volunteer role, you have to have a volunteer role description, and Nikki Sturgeon at the Trust has been incredibly helpful with this aspect of the guidance. In the guidance that we have written, we have based the volunteer role description on an activity volunteer, which is a role that already exists within the Northern Health and Social Care Trust. So this means that the volunteer's role is to assist staff with activities such as arts, craft and music, and the idea is that they're helping support patients or service users in the development of their own health and well-being. So this role of arts facilitator fits very well in this activity volunteer description. And one thing that Nikki would probably agree with, because she mentioned it a few times in our meetings, is that in other trusts, for example, if it's possible to get this volunteer role to fit within an already existing description, it's a lot more straightforward than having to develop a description or a volunteer role description from scratch. So that's the direction that we took with it. Obviously, we also have to consider training, and within most trusts, I would say, that have a volunteer program, they have a sort of essential core training, volunteer training and induction that comes with every volunteer. In the Northern Health and Social Care Trust, that involves an overview of the trust itself and the values of the trust: safeguarding, infection prevention and control, fire safety, information governance, confidentiality, and then the roles and responsibilities of the volunteer and the trust. Now, we do think that volunteers will likely need enhanced training, and all enhanced training really means is that it's additional training to the initial induction that all volunteers get. Now, we do think that these volunteers will need additional training in relation to the arts, but it's less about the arts activities itself and more about the underlying philosophy and how to approach the activities to get those benefits that are linked to the theory. And we also think it would probably be helpful for volunteers to have an overview of hemodialysis, some sort of training or an introduction to the hemodialysis setting before they start, because I think for a lot of people who've never been on a dialysis unit, it can be very overwhelming at first whenever you go in, and it's a very unique clinical setting. I don't think there's many parallels anywhere else in healthcare. So we thought that would be helpful for volunteers to have before they go onto the unit. And then something that has to be considered for all volunteers, no matter where they're volunteering, is supervision. All volunteers will need a named supervisor. No matter what the organisation is, no matter what the role is, they need supervision. The supervisor should be identified by the service manager. So in this case, manager within the renal unit, and they will be able to identify who's best placed to support the volunteer. Now, because we developed this guidance according to a blended approach, that means that there's actually slightly differing requirements in supervision needs for volunteers. So you can have a different supervision approach for remote provision compared to direct provision. And I've just noticed the typo in my slides, I'm sorry. So with remote provision, it's actually less necessary for the supervisor to be a member of the renal healthcare team in the hemodialysis unit, because the volunteer isn't going to be coming onto the unit themselves to work with patients directly, which means that you could identify someone else within the healthcare trust to supervise the volunteer who might be better placed to address their support needs. So for example, the idea that we had was an artist in residence. If that is available within the trust, they might be better placed to support volunteers in that role. However, with direct provision, because the volunteer will be coming onto the site working with patients, they will need a supervisor who's a member of the healthcare team who will be present and working on that unit. Now, it's important to also highlight the fact that volunteer supervisors don't need to be a one-stop shop, because I'm aware that you might not have a member of a healthcare team who's very into art, and they might be a bit intimidated by the idea of supporting someone as an arts facilitator, but that's not necessary. They don't need to be an artist to support this volunteer, and they can signpost the volunteer to get their support needs addressed somewhere else, and they just need to be the point of contact essentially on the unit.